All right, good morning. Appreciate everybody taking time this morning to join in on our first kind of webinar podcast topics throughout pathophysiology. This is something that I'm going to make an attempt to continue to do throughout the remainder of the year. And it's really in an effort just to ensure that that you guys as students and eventually medics have a resource for kind of updated information, diving into topics a little deeper than you would typically get into during the paramedic program. And hopefully this will encourage a lot of you to start doing some research on your own and investigating a lot of these different disease processes that we can see pretty typically throughout our field time, and may just want to know a little bit more information about it. So a couple of ground rules. I do have everybody muted. If you do have any questions, go ahead and type them in the chat. I am going to record this so that it can be watched later by anybody that was unable to attend. I'll go through this. It shouldn't be much longer than an hour tops. And should you have any questions, I'll open up a question and answer session at the end, and we'll go through that. There'll also be a short 10-question quiz at the end, just to track and see, if you are able to retain any of this information. So without anything else, I'll go ahead and get started. So like I said, today we're going to be discussing preeclampsia and eclampsia and some associated diseases within that kind of disease paradigm. So the objectives for this morning, you should be able to describe and identify anatomy and physiology specific to preeclampsia and eclampsia. Be able to describe and identify signs and symptoms consistent with preeclampsia and eclampsia. You'll be able to describe and identify pathophysiology specific to these two, as well as be able to describe and identify emergency treatment modalities consistent with the national scope of practice for the paramedic. Towards the end, we'll cover and you'll be able to compare and contrast associated disease etiologies like the HELP syndrome, pregnancy-induced hypertension, and DIC. So preeclampsia, really, what is it? So preeclampsia, it is a pregnancy-related disorder. It's typically identified by this classic triad of symptoms that you may have heard our instructors talk about during the didactic phase. Generally, it consists of hypertension, edema, and protein in the urine. The hypertension generally is a gradual onset that progresses through the duration of the pregnancy. And the edema usually is specific to the face, hands, and ankles. It is known as the major cause of maternal and fetal morbidity and mortality. Just some statistics on it. It does occur in about 7% of all pregnancies and is most often seen in prima gravida, which is the first pregnancy. So the etiology remains unknown, but it's usually accompanied by a few things, and we will discuss this as we get further into the subject. But it can be accompanied by endothelial cell injury, so injury specifically of the microvasculature, increased platelet activation, so we see a lot of clotting in these patients, and then platelet consumption in the microvasculature. So we end up using a lot of our clotting ability in the formation of these microclots. So what population is at risk? So a lot of the research that's been done on preeclampsia shows that most women under the age of 18 tend to be at higher risk. As I mentioned earlier, also first-time pregnancies or prima gravida. It's also seen a higher incidence in those with multiple gestations, so multiple babies, twins, triplets, those those kinds of situations. Those that have a previous history, so they may have had a pregnancy in the past where they were at risk for preeclampsia and eclampsia. It's also shown that family history also can play a part in a higher risk for developing this. Women of advanced maternal age, which is by definition those women that obtain a pregnancy 35 years or older. Women with a history of already chronic hypertension, renal disease, and diabetes mellitus also have been shown to be higher at risk for developing preeclampsia and or eclampsia. So what is severe preeclampsia? And so severe preeclampsia is identified when systolic pressure exceeds 160 millimeters of mercury, or the diastolic is higher than 110. Other severe symptoms can include headache, dizziness, nausea, vomiting, agitation. It's also been shown to be associated with rapid weight gain, visual disturbances, where they'll see kind of floaters within their visual field, and also abdominal pain. It's usually in the right upper quadrant and can also present with epigastric pain. So a lot of these can be more or less described as typical pregnancy-related discomfort issues. We know that as that fetus develops in the uterus and increases in size, it starts pressing on a lot of the abdominal organs. Women can tend to have chronic epigastric pain, and they just associate it with heartburn because of the pressure and the dislodgement of the stomach. So what are some diagnostic criteria? So diagnostic criteria for preeclampsia, as I mentioned, it's a blood pressure that's usually greater than or equal to 160 over 110. Protein in the urine. If you were able to obtain any kind of lab values from a clinic or from a skilled nursing facility or some other medical facility, you would look for protein in the urine that is greater or equal than 5 grams in 24 hours. Oliguria, which is a decrease in overall urine output, is defined as less than 500 milliliters in 24 hours. We talked about epigastric pain and having visual disturbances. They can also present with pulmonary edema and no history of CHF or lung injury. So, well, what do we do? Well, once the diagnosis is made, the typical goal is maternal stabilization, stabilizing those blood pressures, supporting kidney function, those kinds of things. Typically, these patients, once that either diagnosis is made or they're at risk, will be put on some form of bed rest. Oops. In emergent situations, as pre-hospital providers, we may have to look at administering antihypertensives and anticonvulsants or antiepileptics. Generally, these are going to include magnesium sulfate, and then our antihypertensives specifically are going to be medications like hydralazine or labetalol. Obstetric management is based on the severity of their signs and symptoms and the gestational age of the fetus. In these patients who've been diagnosed with severe preeclampsia, if they're term or near term, delivery is usually indicated. So if severe preeclampsia is present, as I mentioned, it may require administering magnesium sulfate to prevent seizures, along with the administration of some sort of emergency antihypertensive. Preeclampsia, if left untreated, can progress to eclampsia. Now, there's going to be other conditions that have been found to also accompany preeclampsia. These can be things like liver failure, renal failure, cerebral hemorrhage, abruptio placenta, and something called the HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelets. So let's talk about some of the medications that as paramedics we may administer. Again, remember, these are going to be based on national scope of practice. So magnesium sulfate. Its classification is an electrolyte and considered an anti-inflammatory. Its mechanism of action, it reduces striated muscle contractions and blocks peripheral neuromuscular transmission by reducing acetylcholine release at the synapse. All right, so it's going to be that smooth muscle relaxant that also will relax a lot of the smooth muscles in the vasculature and help to lower not only blood pressure, but that threshold for seizures. Another name for eclampsia is toxemia of pregnancy. So you may see that in different literature that you review. But magnesium sulfate is always going to be our first line medication in the management of seizures related to preeclampsia and eclampsia. Because it is a smooth muscle relaxant, it will induce relaxation of the uterus. It does have the benefit of causing bronchodilation after a beta agonist and anticholinergics. So you'll see this often given with asthma and things like that. So magnesium sulfate is a remarkable medication that has a lot of different indications. All right, so what are these indications? So seizures related to eclampsia. It can also be given for torsades de pointes, hypomagnesemia, those patients that are VFib or pulseless VTAC, that is refractory to medications like amiodarone, life-threatening arrhythmias due to digitalis toxicity, status asthmaticus, and bronchoconstriction with impending respiratory failure. So what are some of the contraindications? Heart blocks and any kind of myocardial damage. There are some adverse reactions to the administration of magnesium sulfate that need to be monitored. Drowsiness and CNS depression are common. Some patients experience some respiratory depression as they get sleepy. It's also been seen to cause a degree of respiratory tract paralysis, abnormal ECGs, and even initiate AV blocks. Because of its smooth muscle relaxation properties, it can cause vasodilation, which ultimately leads to hypotension and something called hyporeflexia. And hyporeflexia generally occurs when too much magnesium has been administered. It's a loss of deep tendon reflexes and is often managed in the clinical setting of the emergency department. So how much do we give? So the adult and having seizures associated with pregnancy, the typical dose is 1 to 4 grams of a 10% solution over 3 minutes IV. There are some special considerations to be aware of. Magnesium sulfate does have a pregnancy category D, which is confirmed evidence of human fetal risk, but may be used cautiously, and administration in this case is justified. Seizures while pregnant not only affect the mother, but also the growing fetus, and can lead to things like hypoxia and other things. So it is a risk versus benefit decision to administer mags. And what you'll notice is most protocols in the local counties that you work within more than likely are going to require you to administer magnesium sulfate. So let's talk about hydralazine. This is a medication that is in the national scope of practice. However, you're not very likely to see it in your local counties of operation. So its classification, it is an antihypertensive and a vasodilator. As far as its mechanism of action, is not really known, but it does reduce blood pressure through peripheral vasodilation. It's indicated in pregnancy-induced hypertension as well as heart failure to reduce that workload on the heart. So some contraindications. Obviously, almost every medication has hypersensitivity as a contraindication. In this case, hydralazine also is contraindicated in those that have a documented history of coronary artery disease and heart valve complications. Some adverse reactions and side effects to be aware of: angina, pulmonary edema, palpitations, diarrhea, nausea, vomiting, and of course, a headache. These can all be compounded by the use of a vasodilator like hydralazine. So how much do we give in the adult? 5 to 10 milligrams IV is a typical dose. And it does have a pregnancy safety category of C, which is not recommended for long-term use during pregnancy. However, in an emergent situation like preeclampsia, eclampsia, pregnancy-induced hypertension, it is recommended. All right, our last antihypertensive is going to be labetalol. Labetalol is a beta blocker. It's a selective alpha and non-selective beta blocker and considered to be an antihypertensive. So it lowers blood pressure through blocking beta receptors in the heart and those alpha receptors within the vasculature, which will also cause some vasodilation and decreasing of that systemic vascular resistance and overall blood pressure. As far as its mechanism of action, blood pressure reduction without reflex tachycardia, which is sometimes seen in some of these. Usually that reflex tachycardia is in an effort to improve cardiac output, although our goal is to decrease cardiac output and overall blood pressure through the decrease in not only systemic vascular resistance, but also that heart rate. So when is it indicated? Moderate to severe hypertension. It is contraindicated in a few things like bronchial asthma, heart failure, cardiogenic shock, our second and third degree AV blocks, as well as bradycardia. Bradycardia is kind of an obvious contraindication because we know that beta blockers like labetalol are going to decrease heart rate. And if they're already bradycardic, that can actually exacerbate that. So it does have a very long list of adverse reactions and side effects that the paramedics should be aware of. Things like fatigue, weakness, depression, headaches and dizziness are common. It can cause bronchospasms, as well as wheezing, difficulty breathing, bradycardia, heart failure, pulmonary edema, orthostatic hypotension, which is what we're typically assessing for in the field. In some cases, it's been shown to cause or be the cause of ventricular dysrhythmias, as well as nausea, vomiting, and diarrhea. So how much do we give? In the adult, it's going to be 10 milligrams IV over 1 to 2 minutes. And you can repeat this or double it every 10 minutes to a maximum dose of 150 milligrams. Essentially, you're going to give that initial 10 milligrams over 1 to 2 minutes, and then you're going to repeat it to titrate to your target blood pressure. Some special considerations: it does have a pregnancy safety category C, just like hydralazine. Blood pressure, heart rate, and ECG need to be monitored continuously because of the effects on the heart. And we want to observe for signs and symptoms of heart failure, bradycardia, and bronchospasm. And this really should only be administered to patients who are already laying flat in the supine position. So let's go on and move into eclampsia and talk about what it is. So eclampsia occurs when that preeclamptic patient experiences a seizure. Eclampsia typically occurs in that prima gravida, that first-time pregnancy, and in patients that are multigravidas, and typically over the age of 35. It's also been shown to be associated with those that have a history of renal or some sort of other chronic hypertensive disease. Eclampsia also requires the administration of mag sulfate in addition to antihypertensives when that's indicated. During eclampsia, it's been shown that uterine blood flow decreases, which means the paramedic is going to need to also do their best to try to monitor fetal heart tones. In a clinical setting, this is usually done with a Doppler. Unfortunately, we don't usually have those in our ambulances, so you may need to directly auscultate using a stethoscope, which may be difficult in that environment. While preeclampsia usually resolves with delivery, both preeclampsia and eclampsia can still be seen 10 to 14 days postpartum, which means if you have a seizure patient who has recently delivered in the last 10 to 14 days, it should be suspected that this is eclampsia and be treated accordingly. Most postpartum cases, however, are seen usually within the first 24 hours of delivery. So the eclamptic seizure. When a seizure occurs in pregnancy, you end up with two patients, the mother and the fetus. Seizures can be caused by hypertension, toxemia, preeclampsia, or a pre-existing seizure disorder. It's also important to rule out any cause other than these, like trauma, as the main focus of the seizure. Treatment for pregnant patients is especially difficult because benzos and phenobarbital, which are commonly used for treating seizures, can cross the placental barrier and cause fetal distress. Fetal distress can be seen as a decrease in heart rate, decrease in overall movement as well. If that is suspected, then this should be a code 3 return to the nearest medical facility. Typically those that have NICU ability. All right, in a pregnant patient with a seizure, mag sulfate is the recommended treatment, especially in the patient with eclampsia. There are some potential complications of these patients seizing. Abruptio placenta has been shown to have an increased risk during seizure. Hemorrhage, as well as disseminated intravascular coagulation, or DIC. And in worst case scenarios, even death. So what are some other associated conditions? The first one we're going to talk about is pregnancy-induced hypertension. So pregnancy-induced hypertension is often an early sign of preeclampsia. This will be evaluated by that patient's obstetrician, and they may, based on their history, recommend bed rest. In the third trimester of the pregnant female, typically a normal blood pressure is somewhere around 125/75 or lower. Remember that in the developing fetus, as well as the physiology of the mother, she will increase her circulating blood volume by 40 to 50%. And to account for that extra blood volume, they will have enlargement of the heart and kidneys. Yet they can also be what we would typically refer to as hypotensive as their normal baseline. So when we do see pressures higher than 140/90 with the following signs and symptoms, you should consider this an emergency. So hyperreflexia, where they tend to be a little bit more jerky in their motions, confusion, headache, epigastric pains, seizures, and coma should all be considered an emergency in that pregnant patient. So let's talk about DIC, or disseminated intravascular coagulation, and what that is. So DIC occurs as a complication of diseases and conditions that accelerate clotting. These cause small blood vessel occlusions, which can cause things like hypoxia, organ necrosis, and then overall depletion of those circulating clotting factors and platelets because they're all being used up to cause these microclots. Just having those clotting factors floating around can actually activate the fibrinolytic system and can start to break down a lot of these clots that have been made. And so this is a cascading system in the hemostatic process for blood clotting, where all of their blood factors or blood clotting factors are used up. And then the fibrinolytic system will start to break down those blood clots and can usually result in some sort of severe hemorrhage. Causes, typical causes of this have been shown to be from infection, as well as some of the obstetric complications like abruptio placenta, amniotic fluid embolism, which can be seen during labor and delivery. In that spontaneous abortion patient retained dead fetus, which leads to sepsis and also eclampsia. DIC is also shown a higher risk for those that have cancer, and then also those that have suffered extensive burns and trauma can also lead to DIC. So what is the pathophysiology of DIC? Well, they're not really certain why certain disorders lead to DIC. The consensus is that whatever the triggering mechanism is, it's probably the introduction of some sort of foreign protein. That results in some sort of vascular injury, which results in an accelerated clotting. And if you kind of recall the process of hemostasis, when there is endothelial injury on the inner lumen of our blood vessels, you end up getting the activation of prothrombin, which will convert into thrombin. So when you have this massive clotting and endothelial injury, you end up using a lot of these factors. Thrombin then is going to convert fibrinogen into fibrin, and that's what kind of holds these clots together in the microcirculation, and that's what ends up leading to a lot of this organ and tissue injury. It does use the majority of our circulating coagulation factors. And because of the activation of the fibrinolytic system, which is the clot busting factors, to dissolve those clots, you end up with this clot formation and clot breakdown until we don't have any additional factors available to stop any kind of severe hemorrhage. And so basically that hemorrhage may be the result of that anticoagulant activity of the fibrin degradation products, as well as the depletion of all the plasma coagulation factors. So it is a cascading spiral of symptoms and processes that end up basically being presented as severe hemorrhage that's not easily controlled in the pre-hospital setting. So what are some signs and symptoms? Well, clearly abnormal bleeding. You may also see what's called cutaneous oozing of serum. That's weeping through the skin. You may also see small little bruises or petechiae and even blood blisters on the surface of the skin. You'll notice that your IVs will bleed around the catheter. If they've had any recent surgery, they'll also bleed from those incision sites. They can also present with GI bleeding, epistaxis, and hemoptysis. So now we'll get into two conditions called MAHA and HELP. So pregnancy-associated hemolysis. So MAHA is microangiopathic hemolytic anemia. And this can occur in pregnancy as a complication of preeclampsia, eclampsia, or placental abruption. The HELP syndrome, which we talked about earlier, can occur in 4 to 12% of patients with severe preeclampsia or even eclampsia. It is a distinct clinical entity, and treatment in the field is limited to treating the presence of preeclampsia and or eclampsia with rapid transport. So basically, all we're really able to do in these patients is to treat what we see, which is going to be any seizure activity and potentially try to decrease their systolic and diastolic blood pressure through medications like labetalol. I do want to caution the unauthorized use of medications like nitroglycerin in an attempt to decrease blood pressure. That is not a recommended medication to give. You really should be giving a beta blocker or some sort of other vasodilator to decrease blood pressure. In the presence of preeclampsia, hemolysis, elevated liver enzymes, and low platelet count is collectively known as the HELP syndrome. It can occur with minimal signs and symptoms of preeclampsia, and it's not really entirely known why this happens or how, but preeclampsia can be associated with microvesicular fatty infiltration of the livers, which is what's causing a lot of that right upper gastric or right upper quadrant pain, and with localized or systemic endothelial damage, which is damage to those blood vessels, which can lead to this hemolytic anemia. If left untreated, HELP can result in hepatic failure or rupture, DIC, or CHF. Treatment is always going to begin with prompt delivery of the infant, followed by supportive care. So in our preeclampsia patients that progress into eclampsia, severe hypertension patients, seizures, the typical definitive treatment for that patient is going to be to deliver that newborn. So here's just some numbers for you. In the clinical setting, what they'll use to diagnose HELP is they'll look at their platelet count. And a platelet count of less than 100,000 microliters will basically indicate that they may be moving in this direction. Liver enzymes like lactate dehydrogenase greater than 600 or a bilirubin greater than or equal to 1.2. And then another type of liver enzyme, which is serum glutamic oxaloacetic transaminase of greater than 72, has been shown to support this HELP diagnosis. It still is unclear if HELP is a separate entity or is just a variant of preeclampsia. Signs and symptoms of HELP typically are epigastric pain, right upper quadrant pain, nausea, vomiting, which can also be seen in preeclampsia. Unfortunately, this is often missed and diagnosed as something other than HELP, like gastritis, cholecystitis, or hepatitis. All right, so summary. Preeclampsia is associated with a triad of signs and symptoms, as we mentioned, generally a blood pressure greater than or equal to 160 over 110, edema involving the face, hands, and ankles, the presence of protein in the urine, which isn't something that we're going to really be able to identify in the pre-hospital system, but it may be a good question to ask your patients if they're currently being seen by an OB physician. Preeclampsia has been shown to be associated with pregnancy-induced hypertension, MAHA, HELP, and DIC. Treatment in the field is mostly supportive with monitoring of both mother and fetus. Seizure prophylaxis may be indicated. You're always going to refer to what your local protocols dictate. Eclampsia should be considered in the presence of seizures in the pregnant patient. Our first-line anticonvulsant medication is going to be magnesium sulfate. And if local protocols allow the administration of an antihypertensive such as labetalol or hydralazine should be considered if the patient's hypertensive. Definitive clinical treatment is always going to be the delivery of the newborn. Okay, now let's get into some questions. So I have a question that says, why is nitro not a good idea strictly because there are better options related to pregnancy specific? Nitroglycerin is a potent vasodilator, and without really understanding what that's going to do to the overall blood pressure of that patient, it's just not a medication that is typically used to treat this. We know that nitroglycerin has some outstanding cardiac effects in terms of decreasing cardiac output and overall myocardial oxygen demand by decreasing preload and afterload. And we know that it will lower blood pressure. I would say that if this is your only method of decreasing a patient's blood pressure who is in a critical hypertensive state, I would reach out to your base hospital and have that discussion with them before administering it. It's just not something that I've seen in any protocols. Any other questions on the material that I briefly went over? Okay. What I'm going to do is I'm going to put a poll. All right. I'm going to go ahead and drop a poll here for you. And I'm going to pause recording here for just a second. Okay, so we're going to go ahead and do a poll. And then we'll see what the results are of this. Let me, all right. So the poll is up and running. Give you guys a chance to go ahead and answer those. All right, thank you everybody for your time. This is going to be hopefully a reoccurring lecture series. For the next month, I'm going to be covering a few topics all related to OBGYN emergencies, things like gestational diabetes, talk about Braxton Hicks contractions, causes and pathophysiology behind abruptio placenta and previa, and as well as ectopic pregnancy. I will have my contact information in the video. So if anybody has any questions or comments, feel free to reach out and let me know. I appreciate everybody's time, and we will all get together again next week. Thanks again.